And Dr. Ragini Parekh, now she is going to speak to us on the whenever you are doing the FECO, so and you come across the complication, so
Uh,
you learn from your mistakes. So after doing the 85,000 cataract surgery, she is just telling us the experience, learn from the mistake. Dr. Ragini Parekh.
Thank you, sir. Respected Padma Bhushan, Dr. Naushir Shroff, sir, Padma Shri Dr. Lahane, sir, Tushar Agarwal, sir, Dr. Harvansh Lal, sir, who is the president of AIOS, all my senior teachers and friends. And I would like to acknowledge the presence of one boy who is like a son to me. His name is Vikram. All the facilities that you see on behalf of the company, he makes a lot of effort to do this. So, Vikram, I'm really proud of all the work that you do for these conferences. So, what are the mistakes that can happen and what could have been changed? Mature white intumescent cataract, black cataract, posterior polar cataract, all these patients can create trouble. So, as you can see over here, this is a white cataract. The capsule has been stained and a capsulotomy is being done. So, which is very important, and the stain really helps. A small capsulotomy has been done so that in case there is a problem. As we were discussing in the previous session, that this is a direct chop and you can either trench or do a chop. So patience is very, very important over here, and as you can see over here, we are trying to do phacoemulsification and aspirating the pieces. A little bit of haste at any given time can cause problems. This is the last piece and one has to be very careful during this time. But if that does not occur, then what can happen is that now we are using the single port aspiration cannula and the AC maintainer to remove the cortex. 360 degrees of cortex removal is possible. You are finishing it and you are very happy that in a mature cataract phaco has been done. And now can you see this? We are trying to remove this, the cortex under the instrument, and you can see a PC tear. So instead of that, what could have been done is another port could have been used instead of this. So you can see a PC tear, and now what is to be done? You take a small micro forceps, put viscoelastic and convert this PC tear into a PCC. So this patient, there is a PCC. Jaffe, when I was reading it as a student, always mentioned that it is not the loss of vitreous, but where vitreous is not supposed to be. And the IOL was put inside the bag. This is a second case where you are doing a phacoemulsification and you start with the trenching and do the second division, remove all the pieces. This is the cortical matter remaining with the AC maintainer, as we always do. You remove it. 360-degree cortical cleanup is possible. You have to be very careful. Sometimes we've had problems. Now you are putting in the intraocular lens. Everything is very good. The lens is going in under BSS. There's nothing untoward that has happened, but as you can see over here, there is a PC tear. Sometimes there is a small pre-existing defect or the stretching of the back. So if you recap this again, you don't seem to have created any problem or a mistake in doing this surgery. The IOL delivery was smooth. There was no haptic which was creating a problem, but there was a PC tear. And so, you know, sometimes if anything has to go wrong, it will go wrong. This is the third patient in which you are not able to do phacoemulsification. The exposure of the needle is more than that is required. It should be much less. But there is no phacoemulsification happening. There is no power. And as you can see, that the needle had chipped off and that is why there was no transmission of power. This is another case where phacoemulsification is being done. You do the first division in a standard stop and chop, or you can use two techniques combined, and you can see here that the chamber is not very stable and you are not very comfortable, but you can see one thing is that a small, either the chopper or something has caused an injury to the sleeve and there is a leak. Fluidics are very, very important in phaco, and since that was not correct, there is a PC tear. There's a piece of nucleus remaining, vitrectomy is being done. The tunnel is extended because I think that time that was the wisest thing to do. Convert it to SICS because otherwise this nuclear piece would have gone inside and then we would have needed a posterior segment and a retina surgeon. So sometimes whenever there is a problem, you have to take a decision in the best interest because complications do occur, but they have to be managed well in the interest of the patient. Sometimes you have to leave the surgery if the nucleus is already in the vitreous. Here the IOL is being placed. Ideally, it should have been a 3-piece IOL, but there must have been some support and a proper vitrectomy. So all surgeons, I was very hesitant to learn anterior automated vitrectomy, but it's very, very important to learn it if you can learn a cataract. Now you can see this is a posterior polar cataract, and we are trying to enter through the main incision. It can cause a unstable anterior chamber, and there may be small defects which may enlarge. So you have to be very, very cautious in these type of patients because they have a small defect, and as you are cleaning the cortex, these defects enlarge. Even when they are not seen on slit lamp, these defects do exist, and again a proper vitrectomy is important. These patients are very, very young, and you cannot leave a mess behind. Of course, you cannot leave a mess behind in any patient, but PPC are very difficult cataracts to manage with regards to PC tear, and the likelihood of PC tear is very, very high, so one must be prepared for all eventualities. As you can see over here, this is another case where phacoemulsification is being done, and you are making the first division. See, the main thing is that anything can go wrong at any stage, even though when you feel. Sometimes at the end of the case, when you are doing hydration of the ports, there may be a descemet tear. So you have to be very, very careful. And you know, from the beginning only, if you are not able to achieve finesse or there is no rotation of the nucleus, then you might doubt that there is something cooking which is not correct. You can come out, put some viscoelastic, reassess the situation, and then you can. Now here the followability. The nucleus is not getting engaged, and there is complete pupillary dilatation. There may be some iris diaphragm movement. So you have to be very careful. You have to assess the situation because this case should have gone on very peacefully with the first division, and the pupil was dilated. Now it is constricted. So as we have noticed, and so you have to be very careful. The patient's eye is very important. It's a delicate organ. We are working within 2 millimeters. I have just a few seconds left. So you can lift the nucleus with the chopper and manage it. You can come out, use viscoelastic and mobilize the nuclear fragments too. So lots of things are possible. Reassessing the situation and then doing it is extremely important in any case where there are complications or complications are likely to occur, or in any case which is not going your way. Thank you, the AIOC and Harbanslal sir, Namrata, Santosh for a wonderful conference, and Andhra Pradesh Shea Society for hosting such a wonderful conference. Thank you so much.
Thank you, Dr. Ragini. I just wanted to ask you, you always use an AC maintainer, never bimanual irrigation aspiration. You don't do that at all?
No, sir, I don't do that at all. I have, somehow or the other, we ended up doing a lot of cases always, and it is very easy to use the AC maintainer and the single port aspiration cannula, which is modified by Lahane sir, give it for autoclaving rather than change it every time in the phaco tubing and all that. So I've been trained to use the AC maintainer and the manual aspiration cannula, and I'm very comfortable with it.
Is the flow better? You find the flow is better?
So it can be, the flow can be managed. That's the best part about it. The bottle height can adjust the flow. Sometimes if you want it little more or less, it can be easily done by the bottle height. Also you have the regulator on the IV set which helps to regulate the flow. And it is very comfortable to use, it is very easy to use, there is no learning curve, and it allows, by changing the ports, complete 360-degree cortical cleanup. So I've been very comfortable with it. Sir.
Thank you.
Thank you, sir.